session to our gentleman, Dr. Haidzir, to proceed our session. The floor is yours, Dr. Haidzir. Silakan.
Thank you, Encik Romizan Jatin, as the chairperson for today's sessions. Dear participants, welcome to the International Webinar Series, Clinical Best Practice in Physiotherapy Management, that organized by the Center for Physiotherapy Studies, University Technology Mara. So my name is Muhammad Haidzir bin Abdul Manaf, and I'm from UiTM. So the title of my presentation today is Functional Training during Rehabilitation Stage or Phase for Patients with Stroke Survivors. Oh, let me share my slide first, sorry. Okay, can you see my slide, Encik Romizan?
Yeah.
All right, thank you very much. So this is the content of my presentations. I will start with the introductions to the introductions of stroke and also the recovery phase that are related to stroke. Then I will explain the concept of the gait analysis. What are the simple or the observational gait analysis that we can perform in the clinical? Then I will relate to the gait training. In related to the gait training, I will talk about the functions of the sit-to-stand training and also standing balance training. And further, I will talk about how we can assess the patient's performance in related to community ambulations. So, stroke is one of the causes of the disability worldwide. It is caused by the disruption to the blood flow to the brain, and depends on the nature and severity of stroke. Patient may presented with the paralysis and weakness of upper and lower limbs. They might presented with the impaired posture control. Some of them might have communications and intellectual impairment that may cause limitations or difficulty to follow instructions and difficulty to relearn new movement patterns. Other factors such as age-related cardiovascular or orthopedic problems that may cause patients to delay their rehabilitation program. So most of the recovery taking place during the first days to months. The first phase will be the acute phase. This phase characterized by the medical diagnostic and medical management in order to prevent progressive damage to the brain and also to prevent secondary complications. So the second phase, okay, this is the second phase, the early rehabilitation phase. The aim of the phase, okay, I can take this a little bit down. Okay, the aim of this phase is to restore functions, and some of the patient might relearn or learn the new compensatory strategies in order to prevent limitations of activity and restrictions of participation. So the third phase will be the late rehabilitation phase. It is lasting from 3 to 6 months. Is the continuations of the early rehabilitation phase. So sorry. Okay, wait. Azuraida Delhi. All right, continuations of rehabilitation phase. This phase is helped to prevent and to reduce the limitation of activity. Also, to limit the restriction of the participation, restrictions of participations. In this stage, if necessary, adaptations to the patient physical environment are implemented and home care is arranged. The last phase, but this is the last phase, but the last phase is lasting longer than 6 months. This is the adapting process for patients to optimize their social functioning and to learning to cope with limitations. In this phase also, our roles to improve physical fitness and also monitor the quality of life. Okay. All right. Okay. Progression is from guided movement to active movement as soon as the patient is stable and able to assume independent control. Okay. This is the suggested functional mobility training during the early rehabilitation stage. For the first one will be the bed mobility that consists sit to stand, supine to start lying activity, supine to sitting activity, and we proceed and progress to sitting, improve the sitting balance performance, later on progress to sit to stand activity, improve the standing balance, and proceed to walking activities. So for this purpose of presentations, I will focus on 3 activity or 3 tasks that related to the community emulation, which is the sit to stand, standing, balance, and walking. Okay, I don't know why I cannot enter it now. All right. Okay, I will start with gait analysis, the observational gait analysis that we can use during in the clinical setup. Okay, before that, I will show you this video. Have a look at this video and try to give or maybe try to outline the missing components of these patients. So you can hear my voice during the recording. Normally, you can see these abnormalities is arise as a result of impairments in flexibility, okay, increase of muscle tone, okay, reduce of strength, movement control, the coordinations, and also postural balance. So the critical area of stun phase, if you can see the stun phase is very critical during for these patients that will need to be addressed, including initial weight acceptance, with stun control, and forward weight acceptance or advancements during stun phase, and also during the swing phase, control of knee and foot for toe clearance and foot placement for the next initial loading, initial stance is very important. So there are few components. You can see here the stun phase, especially during the initial contact, the mid stun, and also the terminal stance, and also the pre-swing. And also during the swing phase, the patient is not incorporate the proper hip flexions and also the knee flexions. The patient's the center of balance is towards the good sides. Okay, by having this quadrupod on the left side, and the patient's postural balance also not in the straight line. Okay, anyone, do you want to share what are the others missing component related to these patients? I can say a lot of expert in neuro, formality. If you want to share something.
Not so lah. You also boleh jaga.
I can see formality, and also I can see Puan Lily.
Right.
So okay, thank you very much for coming. So okay, this is some of the missing component that I explained previously. So in the next slide, okay, in the next slide, in the next slide, okay, I will talk about how to analyze the gait. So the normal observational gait analysis that we do in the clinical setup is by observe using our eyes. Okay, we ask the patient to walk few times in order to capture what are actually the missing components related to the patient. Okay, currently with the new technology, okay, the simple one, we can use our own handphone. So by using the camera on the handphone, you can have the what you call it tripod, and also you have your own computer that install the free available software we call it as a Kinovia. Okay, by having video, you can shot only 1 or 2 sessions of the gait analysis. Okay, you can review the tape many times, and you can reduce the number of time that patients to walk for the purpose of observations in order to prevent the patient become fatigued and the gait is not in order, is not in proper after the fatigue. So And in addition, the patients can see how they are walking. You can show to the patients. Over time, it helps to convince the patients that they are ataupun are not improving after a few sessions of gait training. In this gait analysis, the sagittal plane movement is the best observed and recorded from the side. Okay, this example, that video we can take from the our own handphone. We can slow mo the movement. We can observe properly, or we can transport to the cardiovia software, and we can measure properly by having the angles, moment, and power. But as a clinician, we don't have time to do this. At least we can monitor, we can observe by having the our video sessions, and also we can do session with the juniors and also our members or colleagues in the clinical. In terms of we can use the video for the our CME session in the clinical setting. So this is the typical gait laboratory setup. Okay, quite expensive. Okay, it consists of 3D cameras. Minimum, we should have set up the 3D cameras at least 6. Okay, embedded with the force plate. Okay, you can see that here the force plate. And minimum cost to set up this lab is about minimum 700,000. It depends on the currency and the versions. Okay, normally you can have the Bicon system or quality system in the market now. There are a lot of other equipments or other what do you call it, other brand, but normally in research or university setup, they're using the Vicon, also the Qualisys. So in Malaysia, University Malaya, they have 2 systems, University Malaya and currently UiTM, we have 1 system in the hospital and another setup or setting at the Research Management Center under Faculty of Engineering. There are lots of the gait analysis system in hospital rehab Cheras, in hospital. It's not HKL. I'm not sure Puan Lily nama tu apa, Hospital Tuanku Aziza. They have 1 system in the hospital. And also we have this in the ISN. They have a lot of the typical gait lab setup. However, most of the clinical setup, especially in hospitals, say that it is not easy to use this system because it takes times. You have to fill up the markers. Okay, in order to fill up the markers, the patient have to wear swimming suits for ladies and swimming trunk or tight shirt ataupun very tight trousers in order to put the markers. So it will take times and also it's costly. Okay, this is the 3D gait analysis. Okay, on the right side, you can see this is the real time. Okay, this is on the 3D analysis. Okay, the arrow here, you can see the ground reaction force. The system can calculate the number of the step length, also the range of motion related to this movement, and also it can give the number of the ground reaction force related to this activity. So this is another equipment that's suitable to do to be used in clinical. This is FPDM system. They are using the cryoscope and also the accelerometer. This is commercial equipments. It costs your item to pay about 50,000 to get this system, and that is used for the research related to gait analysis. This is quite simple, easy to use, and you can get the data as soon as possible after the data collection is finished. I'm not sure that you can hear the sound of this video. So they are using sensor. You wear it at the lower limbs, okay, both ankle, like a watch. Or if you want extra data for the upper limbs, you can put it on the both upper limb. and also you can put it at the sternum in order to get data for the trunk. So embedded in the system, they have the algorithm that can calculate ultimately the time up and go stairs, postural control, and all the step length variability, gait speed for each step length and stride length. So easy to use, and you can get the gait parameters. It's not only to get time, it's not only to get number of steps, you can get all the gait parameters by using these equipments. I'm not selling this equipment. I not getting any commission from this company. However, I feel that these equipments should be in the other clinical setup in order to improve our outcome measure in related to gait analysis. Okay. So for gait training, there are about 5 major emphasis in training in related to the independent walking. I'm quoting these 5 key points from the Carr and Shepherds and other latest research that cover these 5 areas. Okay, maybe you can, if you can find maybe other books will say 6 or 7, but I prefer all the clinicians to focus on these 5 major emphasis in order to get the patient to be independent post-stroke patients. Number 1 will be the use of hand for support is discouraged as soon as possible to enable the regaining of dynamic balance. Okay, some of you might listen to my presentation in Sarawak, maybe in other conferences. I will ask these questions. Okay, as the therapist, do you want to prescribe quadrupod or not during early ambulation training? Anyone can answer me? Maybe you can share your experience. I can see Puan Norizan is here. Norizan Zakaria. You want to share something? Okay, Adham bin Zaini. If you want
Tak ada
to
waiting
share
seorang
your
tak?
experience. Sorry? Okay. I don't think anyone would like to share. Okay, never mind. Okay, I will share based on my reading in the literature and also based on my experience during working in the my previous clinical experience. So depends on the assessment. Okay, depend on the assessment. So for example, some of the literature might say that walking aids can assist in early gait stability and safety. Okay, but some will say that prolonged use of this device can be problematic because of patient might increase loading on the good sides rather than pushing or loading on the affected side. So with the prolonged use, the patient also fails to develop appropriate balance mechanism and develop the asymmetry, symmetry gait performance or gait parameter, gait characteristics. So they will promote asymmetry gait performance. Excessive weight shift towards become less on the affected sides. Okay, so advice from the research. However, the research in terms of systematic review says that it depends on our assessment. Okay, walking aid should be considered only after full assessment by the therapist for the potential or maybe you can see more harms in relation to patient stage of recovery and also clinical presentations. Okay, based on my example, okay, for example, I'm working in hospital that have rehabilitation setting. So means that in the acute setting, okay, maybe after 5 days, after maybe 1 week, admit in the acute stage, doctor will say that, okay, we are ready to discharge the patients. What is your plan? Okay. During that time, I'm in control in terms of giving outpatient appointment. So means that even though I'm giving early using of the quadripod, I will see the patient as soon as possible by next week, before we can see that the patient might have contributed to asymmetry in the trunk and poor weight shift to the hemiplegic sites. So we give as early as possible for the appointment, and then we can monitor the patient progress from that, and then we can wean off the quadripod as soon as possible. But depends on the situations on other hospitals. Okay, if the appointment is given to the patients about 1 month after the acute setting, okay, if the not the physiotherapy prescribe the quadripod, but some of the caregiver, okay, might say that, okay, from the jiran tetangga, okay, people from the saudara mara will say, okay, in order to walk, you have to use this quadripod. Okay, maybe the saudara buy the quadripod for the patients and ask the patient to learn using the quadripod without the proper guidance from the therapist. Later on, when it comes to you, after 1 month, you can see this type of pattern in the clinical. And with the increase of muscle tone, and maybe some patient might have certain other presentations, it's quite very difficult for you to change this habit. So again, it depends on the assessment of the therapist and the system that related to your hospital setting. Okay. So number 2 will be the early activity in standing. So this is the video that can I share with you. I've got the video from the YouTube. Okay, what you can see from the analysis, you can see that the weight bearing will through a weaker limb. Okay, sorry, the weight bearing through a weaker limb is avoided, and the patient put so much on effort on the good sides due to the limb instability and weakness. Some of the patient, you can see from my previous video, the patient is never put the load on the affected sides. So this is something that the patient might do if not have the proper guidance or guideline from the therapist. And moving the body far enough is avoided because due to instability or inability to stabilize the foot on the weaker leg. And the movement is performed slowly. And same goes with the sitting down performance. The patient might have might perform the sitting down, might demonstrate decreased control in sitting down owing to lack of eccentric control of the muscles, and will sit down abruptly after moving halfway, okay, half the range, and then the patient might not doing the sit to from standing to sitting properly. Okay, for sit to stand training, before you start sit to stand training, this is what call it like a recipe. Okay, you can think about it before you start sit to stand training. Number 1, as the initial setup, how much that amount of support you want to patient to start off. For example, okay, let's say in the early stage of rehabilitations, okay, you can start with high amount of thigh support. Okay, this is example of the thigh. Okay, I can break it up into the 4 sections. For example, 1/4, okay, half, 3/4, and full support. Okay, you can start with high amount of thigh support during early sit to stand training. Okay, later on you can progress by decreasing amount of thigh support. Okay, this is the example of about 25% of thigh support. Okay, then the next thing that you need to do is you need to train the patient in order to avoid the leg turning. So the patient have potential to do leg turning, either inside or outside motions or movement or pattern. So as a therapist, you can use your knee to control the thigh support and also to control the leg before become the turning out positions. So number 2 will be the height of the chair. You can start sit to stand training by having the highest surface. Okay. Later I will discuss about it. The height of the chair may play important roles for early sit to stand training. Number 3 will be the foot positions. Either you want to ask the good fit in front of the the good fit is in front of the affected leg, or the affected leg is in front of the good leg, or you want to make sure that the foot is placed equally between right and left. Okay. Based on some not judgment like, but some what can I say? Depends on the experience of the therapy itself. Okay, some therapists said to me, okay, in early stage, in order to teach patient to become independent in sit to stand, I will ask the patient to put their good leg behind the affected leg, because to encourage the patient to be able to do sit to stand activity. Later on, okay, not too long, but later on, we can start sit to stand training by having the affected leg behind the good leg in order to put the loading on the affected leg. And later, you can start practice with the focus on the symmetry weight bearing later on, coordinated muscular response, educate timing, ask the patient, teach the patient actively flex the trunk, use momentum to shift the body mass forward in the flexion momentum phase. The feet should be placed well back to allow ankle dorsiflexor to assist with the forward rotations. So increased weight bearing on the stronger leg ataupun in the stronger lower extremity can be achieved, okay, by varying the initial foot position, placing the stronger foot slightly behind the weaker foot in the early stage of the rehabilitation stage. Once the patient able to stand up using the good leg, you need to shift to the okay, we need to shift to the unaffected leg. As the patient improve, the position of the feet can be reversed to focus attention on increased use of the weaker side. Okay, we can use, this is one of the activity to improve loading on the affected side by standing up with one leg on the block. So position the patient in sitting with their affected leg on the floor and their unaffected leg on the block. Instruct the patient to stand up and then sit down again. Ensure that the patient shoulders and knees move forward while moving between sitting and standing, and weight is borne mostly through the affected leg. You can monitor, we as a therapist can monitor the weight bearing of the affected side using weight scale. Okay, weight scale, penimbang berat. All right. So this is one of the example that we can train patient in the early of the beginning. Okay, sitting on the plane, high plane, and the weight bearing through the affected leg. Position the patient in sitting on the rise planes with 25% thigh support. Their affected foot on the set of scales ataupun weight scales, and their unaffected foot on the block which is level with the scales. Position the feet in the plantar grade. Instruct the patients to push down to their affected foot to deflect the scales about 30% of body weight without moving their trunk. Okay, for progressions or vibrations, for less advanced, okay, because the concept of neurorehabilitation is from senang to susah, or from the easy to difficult level or advanced levels. So first, increase amount of thigh support, okay, by decreasing the height of the plane, okay, and then number 2, decrease the weight bearing, target amount on the scales, more advanced, reach to target in front with the unaffected hand. Number 2, reach to target on the affected side with the unaffected hand. So for the training guideline, this is for repetitive standing up. Okay, number 1, okay, depends on the situations. You can start with both leg symmetry. Later on, you can start with affected leg at the behind of the affected leg. So non-affected behind the affected leg. Later you progress to affected leg behind the good leg. So feet must be placed about 10 centimeter behind the knees. To load the affected leg, the foot of the stronger leg is placed in front of the affected leg. This is supported by 2 studies. Seat height must be adjusted to match lower limb strength. Use flat seat with no arms and backrest. Start movement from a trunk vertical positions. Number 5, swing upper body forward, push down through the feet and stand up in order to create horizontal momentum of body mass. Speed up if too slow. Focus eyes on an object at sitting eyes height. Do 3 sets of maximum number of repetitions and increase number as soon as possible. Okay, this is what I mean by having this, what do you call it? Standing up and sitting down from the high surface. Okay, you can use the table, not the table, we call it bobah plane ataupun or planes that can adjust the height of the plane. Okay, position the patient in sitting in relatively high surface, but the feet must both feet on the floor. Instruct the patient to stand up and sit down again. Ensure the shoulder move forward by moving between sitting and standing, and weight is borne equally both legs. Okay, this is example of standing up and sitting down from the high surface. Okay, she asked the patient to move forward the affected side. Okay. Okay, foot position, remember the third component is the foot positions. Okay, the left side will be the affected side. The right side will be the good side. In order to avoid for the good side to involve during this stage, just ask the good side and put the leg in front of the affected side. Okay, you can correct the patient's posture. Okay, you can give some cues according to verbal cues, or maybe you can use tactile cues by tapping the buttock or gluteus, and your left hand can properly adjust the knee. Okay, control the knee. Okay. Okay, next you can proceed to lower chair. The patient movement must then be directed into extension phase with required hip and knee extensions, extensor muscles to produce vertical movement into the upright positions. So the therapist can provide tactile and proprioceptive cue to assist the knee extension. Okay, once the patient able to perform with a quite number of repetitions, and you can see the patients progress with good quality of movement and independently can perform the movement with after a few sessions, you can progress to lower seat height. Okay, you can use the lower stools in order to progress to increase the variations of the training. Okay, I would like to ask questions. Okay, somebody from the floor, please answer question number 1. To progress the difficulty of seated ridge, you would increase the amount of thigh support. So the answer will be yes, true or false. Anybody can answer these questions? However, I don't have any presents or gift to give to you. Okay, just answer the questions. Anybody?
False. False.
False. Okay. Anybody that would like to answer true?
False.
False. Okay, everyone. Zulaika, false. Okay, very good. So the answer will be false. Okay. In order to progress the difficulty of seated reach, you should decrease the amount of thigh support. Okay, question number 2. When reaching for an object on your right, you should predominantly load the right ipsilateral leg, B, the left contralateral leg, C, both leg, C, neither. A, B, C, or D? A. So your answer will be A. Okay, A. Aiman Mubarak. Okay, Khairi Suhaimin, A. Mira Faizal, A. Alright, very good. Oh, terror korang ni. Okay, betul jawapan. Your answer is right. Okay, whenever you do training during standing or sitting balance training, once you improve the directions or you increase the directions on the affected leg, you might improve the loading on the affected leg. Question number 3. Use of hand is an adaptive strategy and should be recommended with caution as it changes the kinematic of the task. Is it true or false? Use of hand is an adaptive strategy, should be recommended with caution, and it changes the kinematic of the task. Is true or false? True. True. Okay, thank you very much. Okay, the answer is true. Okay, last question. I know I'm late already. Now it's 10:55. Okay, when providing manual guidance at the knee during sit to stand, therapists must ensure that the knee move before assisting is to knee extension. Is it true or false? Remember the video? What the therapist do? Okay. Okay. Semua terah dah. Okay lah. It's true. Okay. Now we proceed to point number 3. Balance of the body mass over the changing base of support. Okay. The initial setup with the foot position. Okay. Remember the foot positions. For the reaching activity, movement of body. Movement of the body should be in the direction of reach. Try to encourage reaching on the affected side more in order to load the leg in the direction of reach. So during the reach distance, okay, in relation to foot position, make sure that the patient perform, for example, you can see the picture on the left side, okay, and you ask the patient to swing forward and backward, okay, against the wall, okay, against the standing table. Okay, make sure that the patient is using ankle dorsiflexion rather than hip flexions. Okay, so use the ankle strategy rather than hip strategy. Teach the patient how to perform this. Okay, encourage the patient to use ankle strategies. Okay, this is one of the example by having increasing the standing balance performance, standing and looking up and down. Okay, standing and turning while one leg forward. Okay, standing and leaning forward and backwards. Okay. Moving the affected leg to target in the semicircles activity. Okay, you can ask the affected leg to touch the what do you call it? The square, round, or star and triangle here. So you can ask the affected leg to move. Later on, you can ask the good leg to move in order to maintain single leg stance. Okay, improve the single leg stance on the affected side. Okay, for number 4 and 5, push off through the lower limbs and also control of the knee through the swing phase. Okay, right now. Okay, this is, we call it as the stepping activity. You can start with the lateral movement. Okay, on the picture on the right side, you can have the weight shift prior to stepping, lateral movement. You can ask the patient do the upward movement. Okay, by having the good effect, the good leg on the box, and then later on change the affected leg on the box. later. For the forward movement, you can teach the ankle to control using the ankle strategies. So this is example of rising the leg on the block. Okay, you can interchange between the good leg and affected leg. Both have different target or objective to do this type of activity. You can lowering and rising from the block. Okay, control the knee during step down. We try to improve the ability to stand, walk, and walk up the stairs. Maintaining single leg stance while stepping backward with the other leg. Okay, you can use the good leg and move the good leg behind the affected leg in order to maintain single leg stance. You can start the activity, all the activity, or we call as the locomotor training at the pedal bar in the beginning. Later, you can progress overground training in the gym with the controlled environment, and the environment is safe for the patients. In later stage, you can see during the late rehabilitation phase, or maybe you can start with the chronic rehabilitation stage, how the patient can improve their gait performance in the community setup, okay, or the community, we call it as the community emulation. Okay, community emulation is the ability to integrate walking with other activities in the complex environment. The patient must perform the walking with must safe and must independent in the public space in order to optimize participations. The outdoor walking is very complex activity because it's have different component inside the walking activity. The patient should start and stop and change direction frequently and unexpectedly or sudden. Adjust the walking speed and avoid obstacles. Some of the patient might crossing a street in order to become independent, walking on various type of surface, doing two tasks at the same time, and in other countries, preferably in a variety of weather conditions. So gait, speed, and endurance, sorry for the typo. An average walking speed of 1.32 meter per second is required for safe and independent ambulation in community. So my question is that, what is the average walking speed for community dwelling stroke survivors? Anybody knows? Any of my CI, clinical instructor, can answer these questions? Anyone? Okay, malu. That's okay, take your time. So the average walking speed of community dwelling stroke survivors is ranged between 0.3 to 0.8 meter per second. So therefore, reduced walking speed is a critical barrier for stroke survivors to walk or to participate in the community. In addition to that, compromised walking endurance. Okay, walking endurance for patients with post-stroke is reported to be significantly associated with limited community participations. So therefore, there is a critical need to enhance gait training outcome for patients with post-stroke, especially the component of walking speed and endurance. So the criteria for gait competency in the community, at least the patient able to walk at speed fast enough to cross street safely, at least between range 1.1 to 1.5 meter per second. They're able to walk long enough time and far enough to accomplish daily tasks about 500 meter. Able to turn the head while walking. Use anticipatory strategies to avoid or to accommodate obstacles. React quickly enough to slips and trips and avoid a fall by stepping. They should be able to negotiate stairs, curbs, ramps, moving foot away, and carry objects. Okay, this is one of the outcome measure that we can use to measure patients' gait speed. So the 10-meter walk test used to assess walking speed in meter per second over a short distance the total time taken to ambulate 6 meter, even though there are 10 meter, but we use the 6 meter after the 2 meter and before the and then stop at the 8 meter. Why? Because the first 2 meter is for the patient, we call it as the acceleration phase. Okay, the last 2 meter is the deceleration phase. So we only take the 6 meter range. Okay, you can use 2 trials. Okay, each that recommended. Number 1 will be the comfortable speed, and number 2, as you can ask the patient to do in the fast speed. The 2 trials for each speed are average, and the 2 gate speeds are documented in meter per second. The cut of score and normative value may be used to in conjunction with the complete evaluations to interpret the meaning of patient's 10 meter walk test score. So ambulation ability that is predicted by gate speed is reliable method to classify the patients. Who is Sheila? Okay, all right, sorry. So if the patient have walking speed less than 0.4 meter per second, most likely that the patient is a household ambulator. That's it. Okay, it's just safe to walk in the house. Later on, you could use this gate speed measurement in order to improve the gate performance, in order the patient at least have between 0.4 to 0.8 in order to become a limited community ambulators. If the patient said that their goals to be a community ambulators, you can increase the gate speed by having the gate trainings and make sure that the patient have more than 0.8 meter per second. Okay, the other outcome measure that can be used to measure the gate performance by measuring the time up and go test. Okay, TUG test is the performance-based tools used to assess balance and mobility, performance, as well as turning ability in the population with prior diagnosis, and can be used for stroke patients. The TUG test measures time taken for an individual to stand up from a chair, walk 3 meters. Okay, walk 3 meters here, make a turn around. Excuse me. Walk another 3 meters back to the chair, and then sit down. Okay, the time taken to complete the TG test has been shown to predict falls in community stroke and also the elderly. Furthermore, if the patient takes more than 5 steps or more than 3 steps, if the patient taken more than 5 steps and more than 3 seconds to complete the turning here, okay, he or she is considered to have turning difficulty and high risk of fall. So the TG test consists of dual task condition as well. Previous study have shown that performing TUG test under dual task conditions increase the time taken to complete the task. Okay, you can see the video here. Skillful turning during walking is one of the key factors for the ambulation, fully functional ambulations. Stroke survivors with sensory motor impairment may have difficulty in organizing proper turning sequence. You can see here is if we ask the patient to make a turn, they have difficulty to organize proper turning sequence. This may put them at risk of fall. As we can see, patients have presented with staggering or loss of balance during turning. For temporal special gait parameter, individual with stroke had delayed initiation of turn. They turn with slower gait speed, asymmetrical step length and width, and took a longer time and step to complete the turn. Okay. The last component will be the exercise capacity after stroke. In addition to specific neurological deficits, many of stroke survivors has very weak conditions due to the loss of muscle strength, loss of activity, they become very deconditioned. And previous study has shown that peak aerobic fitness have reduced 50% as compared to age match control. This very low work capacity coupled with impaired working efficiency may result in marked loss of the capacity for activity daily livings. In order to measure the walking endurance for stroke survivors, especially for ambulatory patients, walking endurance can be measured using 2 or 6 minute walk tests. The time and total distance, especially the total distance of rest, number of rest stop and symptom as rest stops are recorded. Shorter distance, for example, 2 minute walk test can be used for patient with acute stroke. During the test, the patient can stop to rest or use in assistive device as needed. Okay. For example, previous study have shows that the mean or the average of the range that covered by stroke patients for 6 minute walk test is about 400 meters, the mean. Okay. And for this 2 minute walk test, patient stroke may presented with may cover about 150 meters. So by having this test, okay, for example, your patients during the first test only can cover 50 meter for 2 minute walk test. So this shows that the patients have quite low in terms of their walking endurance. So therefore, you need to prescribe at least aerobic exercise or walking training for longer range in order to improve their walking endurance. So minimal clinically important difference will be the 54.5 meters to show that they are beneficially improved when you start your gait training in order to improve the walking endurance. So to make sure that, for example, if you take the 6 minute walk test, maybe after 2 weeks or maybe after 1 month following your gait training, if you can see that there is an increasing of 54.1 meters, it will show that the patient have benefit the gait training that prescribed by the therapist. So for that, in order to see improvement, at least minimum 54.5 meters improvement after the gait training by the therapist. So exercise prescriptions after stroke. Okay, you can prescribe aerobic exercise for the patients with stroke. Number 1, determine comorbidities and their effects on the patient functional capacity. Determine the patient ability to walk in distance and minutes, and their ability to use modified equipment such as recumbent bike and maybe a treadmill with the harness. In terms of frequency and durations, we can start 5 times per week if the patient cannot tolerate 15 minutes of walking or stationary bike. Then progress to 3 times per week if the patient can walk for more than 15 to 20 minutes with or without periods of rest. In terms of intensity, okay, I do believe that you can read from this Cochrane database, latest by Cochrane in 2020. The target heart rate should be about 50 to 70% of the maximum heart rate obtained by 220 minus the patient age. However, my advice for patient with stroke, please use heart rate reserve formula, okay, rather than maximum heart rate formula. So the general rule will be the 15 to 30 beats per minute above the resting heart rate. Or if you can use the RPE or box scale, there are 2 types of box scale between 6 to 20 scale. Make sure the patient do the exercise between 12 to 13 or 4 to 5 on the 0 to 10 scale. Always start with warm up and finish with cooling down for the improvement of range of motion and also flexibility. Each warming and cooling down will be the 5 minutes. So this is recommended. Okay, if you start the exercise by low intensity, okay, this is the max, the heart rate reserve. Okay, make sure you can start with less than 40%. Okay, box scale between, if you use 0 to 10, be less than 5, or 6 to 20, less than 10. For moderate, this is the heart rate reserve, and this is the box scales recommended. And if you want to start any vigorous activity, this is the heart rate reserve and also the box scales. Okay. To prescribe cardiorespiratory training, you have 2 types. Okay, the first type will be the MICE, moderate intensity continuous exercise. Okay. If you start the patient on the recumbent bike or static bicycle, you have 5-minute warm up. Okay, this is the peak work power output or the heart rate reserve calculation here. Okay, if you start with the 40%, okay, the warm up will be about 20 to 30% of the heart rate reserve. And then you can ask the patient continuously for 20 minutes. Okay, but some studies said 45 minutes. But for me, you can start with 20 minutes. Okay, sustain and continuously walking on the treadmill or using the recumbent bike for 20 minutes and later 5 minutes cooling down. However, some studies in the previous study shows that most of the patient with increased muscle tone might have difficulty to maintain or to continue continuously walking. Therefore, the current study have recommended the high intensity interval training because the high heat have interval in between the activity. So we have 5 minutes here, and then 5 minutes of 30% or 30% heart rate reserve, and then you can have the burst. Okay, burst. The maximum will be about 40 to 15% if you start with the light. Okay, and then you have another rest, passive rest. We have another burst, and you have another rest. So the patient at least have rest in between the burst. Okay, and the previous study shows that heat improve both aerobic and also the motor outcomes, especially the walking speed if you are using the treadmill with the harness. Excuse me. So this is 3 types of heat for patients with stroke, but I recommended that low volume heat is suitable for early beginning of the stroke ataupun for early stage of stroke. Okay, ataupun patient that started would like to start the aerobic exercise. So because the burst duration is only 10 to 30 seconds, but the recovery period duration is between 2 to 4 minutes. So they have the burst recovery ratio about 1 to 4. This is light active exercise, and it will cost about less than 30% of your to peak. So later on, once the patient improve better and there is no adverse effect, you can change to other type of activity. For example, long interval HIIT, or maybe you can start after the low volume will be, you can start with short interval. However, the short interval will be quite extensive for patient, may cause fatigue because the burst duration is about 15 to 60 seconds, and also the recovery period will be the 15 to 60 seconds. The burst ratio is about 1 to 1. So okay, I'm getting permission from my colleagues in University of Sydney. They are doing research on aerobic performance after strokes by using the isokinetic cycle. In addition to improve cardiorespiratory fitness, it might also improve muscle strength, power, and also endurance. Okay, putting it all together, physiotherapy can restore feed-forward mechanism through very task-specific training. Okay, task practice should be varied with the concept of from easy to advanced stage. Okay, and should be challenging for the patient from time to time to ensure that the cortical connection necessary for different task demands are developed and strengthened. Practice has been associated with an increase in the strength of the functional connectivity within the motor regions. Practice should be sufficient to cause changes in cortical activity. As summary, task-specific training of sufficient intensity and repetition is important following stroke in order to optimize neuroplasticity and motor learning. In order to enhance gait performance for community ambulations, we should include the walking speed and walking endurance training. Therefore, the end of sessions. Thank you very much. How to stop sharing? Okay.
Okay, thank you, Dr. Haidzir, for your informative presentation, impressive presentation. Now we go to our Q&A session. I look at this chat box. There is one question. right?
Only.
Only for the time being.
Okay.
For the time being. Okay, for the time being. Don't worry. For the time being. Okay. One question from Aiman Nadia. Okay. What types of HIIT activity suitable for stroke population, Prof? And then, is it suitable to be conducted in clinical setting? Then third one, what precaution we should take? There's three components in this question. Silakan.
Okay.
Zee.
Thank you very much, Puan Aiman Nadia. Okay, the HIIT, sometimes the HIIT is something that may be different a little bit as compared to HIIT for healthy populations, because in order to get the HIIT, you must achieve, if you are using maximum heart rate, you must achieve more than 70% of maximum heart rate. But definition for stroke patients, sometimes lesser than 70% is considered as HIIT also for the patient, because we need the component of high intensity and also the high intensity and also the interval training. So in the clinical setup, okay, normally for stroke patient, based on previous study, they are using two types of training. Number one, treadmill training with harness, must be with harness, because to avoid patient sudden collapse ataupun sudden falls if the patient cannot tolerate the activity. And number two, using the recumbent bike. Okay. However, based on study, because the concept of motor relearning, if you want to improve other than aerobic exercise, if you want to improve the walking pattern, you must train the patient using treadmill in order to get either aerobic performance and also the gait performance. So they are preferred to use treadmill training with harness. Okay. However, because in certain ethics in Malaysia, they have difficulty to perform HIIT because in terms of issue with their patient safety. Therefore, HIIT normally we prescribe the HIIT after or during the chronic rehabilitation stage after more than 6 months. At least the conditions of medical situation is more stable. The patient able to walk with certain criteria. At least patient able to walk at least 1.0 meter per second gait speed on treadmill more than 3 minutes. There are certain guidelines that are not specific, but they have certain guidelines based on previous study by using the HIIT. So far we can start, but again, assess the patient capability. If you have access to ECG, you have good connections with the emergency setup, you know where to refer the patient if the patient have any adverse effect, you can start the activity. So preferable, you can start the activity by having low intensity, not the high intensity, low intensity, low interval training first. You have longer passive recovery. Is it cover my question, Puan Aiman? Okay, thank you.
Okay, I will give one more question because we have constraint of time.
Okay.
We have another question from Mira Faizal. Okay, Dr. Haidzir, for issue of using walking aids, what if patient still using the aids even though we already without it in clinical setting? The reason patient still using it because of fear of fall. What would you recommend for us to help this kind of patient?
Okay, thank you, Mira Faizal. Again, I think this question will be asked for by any other therapists in Malaysia, because in current situation in Malaysia, there are a lot of advisor for the patients. Okay, makcik, saudara, jiran. For example, they will prescribe the report before the patient physiotherapy prescribe their walking aids. Okay, so in this, I will always tell other therapists in KKM lah, can you increase the number of session per week? They says this is very impossible to increase the number of session, at least to get two times per week, because the patient require prompt by the therapist. Okay, even though they are training without the gait, they will still using the gait during the community walking because of fear of fall. Okay, they say that if they are using the walking aids, people will recognize them as the people with disability. Then there will be precautions of people for not hurting the patient of or maybe hit the patients. So advise the patients, you can use the walking aids, but not emphasizing on the loading the weight on the good side. Just use the walking aids as the, what you call it, as the precautions for others for not hitting the patient or hitting the patient during the community walking. So however, this is very good question, because if you see from my video, the first video, the patient is reluctant to throw away his quadripod because of the, you can see the ankle cannot push during the mid-stand process ataupun phase, because the patient have high, according to the patients, there is no training from early beginning in terms of improving sit to stand. There is no someone teach them how to load the weight bearing on the affected side. Therefore, the patients develop the pattern of the ankle plantar flexor and also the increase of the muscle tone. And when the patient start to do weight bearing on the affected side, the patient complain of pain already. So therefore, as soon as possible, make sure that you load the affected side from early of beginning. So you can easily to win off the quadripod. Okay, is that answer your question? Hopefully help to answer your questions. Okay, thanks, Cik Imrizan. I think this is the last questions.